Good afternoon. Let's begin. It's a very lively crowd, and I'm sure you'll enjoy our presentation today. It's one of a series on leading vision in public health education. We're really pleased today to have Sandro Galea here. Sandro has been to Georgia State before. He is currently the chair of the Department of Epidemiology at Columbia, Mailman School of Public Health, where he has a faculty of over 150, $100 million in research portfolio, and over 400 students just in the Department of Epidemiology. So it's a big operation that he is in charge of now. Sandro is internationally respected physician and epidemiologist. He received his MD degree from the University of Toronto, his MPH from Harvard, and his DRPH from Columbia. His interest is in the social production of health on urban populations. His work particularly explores innovative ways to explore population health, looking at brain disorders, social determinants, and the consequences of trauma and conflict. His research has included looking at the effects of September 11th, Hurricane Katrina, conflicts in sub-Saharan Africa, and wars in Iraq and Afghanistan. He's published over 450 articles, if you can only imagine doing something like that. He has a new book out on Epidemiology Matters, a new introduction to the methodologic foundations. He's chair of the New York City Department of Health and Mental Hygiene's Community Service Board and sits on the Board of Health in the city of New York. Past president of the Society for Epidemiologic Research and an elected member of the Institute of Medicine. Beginning January 1st, Dr. Galea will begin his tenure as Dean of the School of Public Health at Boston University. And he's sure to continue to be a leading voice in public health in the United States. Perhaps most significantly, Sandro has his own Wikipedia page, and he is very active on Twitter. So we know that he has not only an academic and scholarly voice, but also a very nice presence in social media. We're very grateful to have Sandro here as we celebrate our 10th anniversary of our public health program at Georgia State University. So, Sandro, please.
Thank you. Am I on? Yes. Good. Thank you, Dean Erickson, for inviting me and for the very kind introduction. You know, the Wikipedia page is a very funny thing. You just don't know where it comes from. All of a sudden, one day, somebody says, "Did you know?" And then you're like horrified, like, what are they saying? How did they know that? Anyway, so it's really great to be here. And Michael asked me to talk a little bit about cities and health. And I wanted to really do a bit of an overview talk about how I am increasingly thinking about the role of cities and the health of populations. And I call this a subtitle, Thoughts on Emerging Research Questions. I'm not going to be prescriptive about where I think research should go, in part because I think that's boring, and in part because I thought it would be more interesting if I try to provide a bit of a formal framework for how to think about cities in the context of health. And hopefully the talk can be a sort of an agitation, a provocation for you all to think about how this fits in with your work, with your scholarship, with your own education. So having said that, I'm going to plunge right in. And I think it seems particularly appropriate to be doing a talk like this here, both in a great city, but also I think in what is a quintessential urban university. I always admire Georgia State for how it's deeply integrated with the city. And it strikes me that that creates opportunities that other places may not have, but also creates challenges, I can only imagine. But in many respects, any study of, any thinking about cities and health is really the story of joint challenges and opportunities. So let me start with why cities. And I think it's important to keep in mind why cities. And for everybody, and particularly sometimes when one is within cities, it sort of becomes obvious, like, well, because it's a city, why else? But I think it's good to keep in mind why we're even bothering having a discussion within an academic public health setting of why cities. And the obvious primary reason is that urban living is one of the very few common modalities of human experience that transcends borders worldwide. So about 54% of the world's population lives in cities right now. About another 2.5 billion people are expected to be added to urban populations by 2050, surpassing 6 billion people. So by about 2050, we expect there to be 6 billion urban residents. And for benchmarking, of course, today in 2014, the whole world has about 7 billion people. So the urban experience has become, and I'll show you when that was in a second, modal, and it is modal worldwide. And if one were to pause for a second and say, what are shared human experiences that are modal to populations worldwide, it's hard to think of many. I think the two that probably come to mind are urbanization, urbanicity, and a growing longevity of life. All throughout the world, people are living longer, and all throughout the world, people are more urban. But apart from those two, it's actually hard to think of many other characteristics that are shared worldwide. Of course, as one might expect, there's a lot of attention paid to cities as this goes on. There's really just a snippet of web pages that one gets very quickly by typing in cities and health. But I want to show you a movie set of slides that really make the point. And this is a map of the world. And I'm going to color in the countries where at least half the population was living in urban areas. And I'm going to start in 1960. And what you see in 1960 is that the countries that were urban were North America, Western Europe, and Russia, at the time was Soviet Union. And the reason I'm starting with this map is because sometimes I can't help but feel that our conception of what is a city is sort of stuck in 1960, in that when I ask you to close your eyes and say, what are you thinking of as cities? Well, you're going to say, Atlanta and Madrid and Paris and New York. I mean, those are cities that come to mind. As I'm going to show you in a second, those are not really the cities that matter anymore. So this is 1960, and I'm just going to go forward in time, 1970, 80. That's 2050. So by 2050, essentially, the whole world is urban, with a few exceptions still in sub-Saharan Africa, where in all countries in the world, more than half the population lives in cities. We had this crossover of urban-rural, and it was roughly around 2008. So this is the number of rural people in the world. This is the number of urban people in the world. We are here at 2015. And the reason I'm showing you the slide is to show that very rapidly, we are achieving curve separation, right? So by 2050, which is what I was talking about here, remember I said it's going to be about 6 to 7 billion people in 2050, it's urban, and while the rural population is more or less plateaued. And when you look at within countries, so this is looks at within countries, and the only reason I'm showing you this is that while some countries, for example, there's actually Hong Kong here is listed as a country, it's nearly 100% urban, the majority of countries of the world, I mean, they're all sort of over 50. I mean, it actually have a very long tail before you get to any of the countries that are still under 50. Now, I mentioned this notion that in some respects, our understanding of urban stuck a little bit in a Western perspective on cities. And there's reason for that. There are some very big cities, important cities in the Western world, to call it that. New York City has more people in New York City than live in 40 out of 50 US states. Right? So the mayor of New York City is the chief executive for a city which is larger than 40 out of 50 US states. About 1 out of every 38 people living in the United States resides in New York City. So these cities are big cities, they matter, but this is a map of the world's 20 largest cities today. And when you look at this, what do you notice? Well, what you actually notice is that the bulk of the world's 20 largest cities are actually not here and here anymore. They are here. In fact, most of the world's largest cities and most of the world's rapidly growing cities are in Southeast Asia and rapidly in Africa as well. This looks at urbanization in low and high income countries. And what you have here is, this is rural population in low income countries. This is the urban population in low-income countries, zooming along. And these are rural and urban population in high-income countries. Those are staying roughly the same. Where we are growing in cities is in urban population in low-income countries. And that, of course, has real implications for how we think about cities and how cities may affect health. And Dean Erickson was telling me that the two of the joint foci of interest of this lecture series are urban and global. In many respects, I don't think the two are extricable, that if one is thinking global, one needs to think of urban. And I think it's a very important way of wrapping our brain around global and global health. In that I were to challenge you, much the same way as I challenged you a few minutes ago to say, close your eyes and think to yourself, what do you think of when you think of cities? I would argue that if you were to close your eyes and say, what do you think of in terms of global and global health? We are stuck in this image that with global, we're dealing with communities that are rural, that we're dealing with people who are really far away from urban centers. Well, that is not what global is anymore, and increasingly, that is not what global is going to be. For any students in the audience, as you come into leadership in public health practice and public health scholarship in 2030, 2040, this notion of global will be firmly intertwined with urban, and the two are completely inextricable. So that's cities. That's cities in terms of sheer numbers. Now, if it were just numbers of people in cities, that would be one thing. But another aspect of cities that is critical to keep in mind is that cities are a lens that concentrate resources. And I'm going to talk a little bit about what those resources are. That it's not only a matter of more people live in cities than people do not live in cities. That cities concentrate resources disproportionately to even their growing population size. One of the most obvious ones is income. This is a figure looking at GDP. This is gross domestic product, and much of the world's gross domestic product is concentrated in its very large cities. In fact, actually, you have Atlanta right there in about a concentrator of gross domestic product. Worldwide, this is Africa, this is Latin America and the Caribbean, this is Asia. What you see here are two curves. This is from State of the World Cities report in 2011 from UN Habitat. The dark brown line is the population urban, and the light brown line is GDP. And what you see here is, and these are only obviously three regions of the world, but I could show it to you for all regions, that we have a lockstep march. As countries get more urban, their economic growth advances as well. China, which is perhaps the country about which we have had most conversation about its rapid economic development lately. What this is a map that shows the annual per capita income by province in China. And what you see here is this is above the mean. The blue is above the mean. The, the brownish is below the mean. And the darker the blue color, you have the more per capita income by province above the mean. And what you see, of course, here is the darkest blue colors are where the largest Chinese cities are, which is Beijing and Shanghai. And in fact, for much of the rest of China, where cities are not growing, you have per capita income that's below the mean. When you look outside of any specific country, you look overall, this curve looks at rural and urban GDP, gross domestic product. This is rural gross domestic product, that's urban gross domestic product. This line here would be where in any given country, the urban-rural GDP gap equals 0. What you see, of course, is that all countries are here. They're not here, right? That means that there is a positive urban-rural GDP gap worldwide. So cities are concentrating resources. And starting at a very fundamental basic resource, in some respects, income is synonymous with the word resource, cities are growing GDP worldwide. So as the world is growing, as the world is accumulating more resources, that growth and that accumulation is almost synonymous with the growth of cities. Now that's income. But things like education. So this is now taking an American lens. This is education in the United States. What you have here is urban, suburban, town, and rural. And this is the white bar is total, and the green bars are male and female. All I want you to see here is that higher education in cities and then in suburbs, then in towns, then rural, that's in the United States. And not just in adults overall, even things like pre-K. This is pre-K enrollment, urban, suburban, town, rural. And of course, this is not inextricable from the observation of the growth of gross domestic product and income. Other resources also accrue to cities. This is looking at the US population again, and we're looking at urban, rural, urban being the red bar and blue being the rural bar. And the top bar just says 75% of the US population is urban. This bar says, where are the doctors? And what you see here is that 90% of doctors in the US, disproportionately higher than they are in urban areas, are in urban areas, while only 10% are in rural areas. I want to pause here and make a point that in talking about urban and urban health, I'm obviously making a case for the growing import of thinking about cities, how cities shape the health of populations, and how, as a result, an urban health research agenda needs to be at the heart of any population health scholarship agenda. That is, of course, not to dismiss the challenges, the problems, the particularities of rural health. And I once did a talk that was similar to this. Somebody said, well, how can you say rural is important? I'm not saying that at all. This is simply, I'm trying to provide a framework for thinking about how cities affect health and why we should think about cities. There is, I think, an equally compelling case to be made that there are particularities about rural areas and health that need to be borne in mind. But that, of course, would be, well, a different speaker and a different talk altogether. This is in the US. This looks at the gross metropolitan product of the US. These are the largest 10 metropolitan areas, and the largest 10 metropolitan areas in the US. This is just the cities themselves. Their GDP is greater than it is the combined output of about 36 states. And this combines the usual suspects that you might think of. And just one last example on this. This is Detroit, a city that's been much maligned lately for many reasons. But downtown Detroit, which is this area right here, occupies about 3% of the landmass of the entire city. But it includes, out of it generates more than 1/3 of jobs that are in Detroit, that are in this high-density space. So not only is it cities, but cities themselves are this concentrating lens of resources in particular places. So that's why cities from a sheer number of people point of view. Then making the argument that cities are inescapable if we are to think about resources. Resources on multiple dimensions, including employment, including human resources, including education. And of course, these are the resources that we all know shape the conditions that produce health in populations. Now, one of the things that makes cities so interesting, and I think makes the study of urban health so interesting, is that cities change. The role of cities change. It also, by the way, is what makes the study of urban health, I think, a little bit difficult sometimes. Because in some respects, it is a moving target. When you remember the graph I showed you about the rapid separation of number of people living in cities versus rural areas between 2015 and 2050, there was substantial separation of those curves over the space of 2 decades. Now, while we, as humans, tend to think of 2 decades as a long time, I think we're all smart enough to realize that stepping outside of ourselves, 2 decades is nothing in the span of humankind, right? But these are changes that are happening, and they're happening very rapidly, and any form of research that's trying to wrap its brain around them needs to understand that cities are changing, and what we observed about cities in 2005 may not be the same as in 2015, and is likely not going to be the same in 2025. So this is looking at urban borders. This is Tokyo, 1972 on the left. Tokyo today on the right, where you see that essentially the urban spread of Tokyo here, which is the yellow, is about, Tokyo has roughly doubled its footprint in the past 40 years. Mexico City, about the same. Mexico City, 1970, Mexico City today, roughly doubled its footprint. So cities are growing, they are gaining physical space, and as they gain physical space, they're also gaining population, and they are gaining in the number of circumstances within those city borders that may influence the health of populations. Populations within cities are changing. This goes back to the US. This looks at segregation in US metropolitan areas. The good news is that black-white segregation in US metropolitan areas has broadly been dropping over the past 40, 50 years, in that on a black-white axis, cities have become more integrated. That's good news. On the other hand, on ethnic group axes, actually cities have become more segregated. This is percent of Hispanic metropolitan areas, and this is all areas, and looking at Hispanic-white segregation, showing in fact there's been growth in Hispanic, non-Hispanic segregation in the US. So it's a complicated picture of how people of different races and ethnicities are coexisting in cities. A lot of city growth comes from population movement. People move, and people move much more in cities than they do in non-cities. This is a world map. And what this shows is the likelihood of areas becoming urban by 2030 as driven by population movement. And what you see here, in particular, separate and apart from certain Western European countries, in the Middle East and in Southeast Asia, there is tremendous bands where people are moving, and they are moving into cities. They're moving into cities, making cities larger, and changing the composition of those cities, changing the interaction of populations within those cities, changing the structures that produce health in those cities. This comes back to the United States. This looks at Washington, D.C. And what this graph looks at, these are ages. So these are under 17, 1834, over 35, and over 65. And this says what proportion of that group that currently lives in D.C. lived there a year ago. And what I want you to see here is that in the 18 to 34 group, more than half, about 70%, a year before did not live in D.C., in Washington, D.C. While, of course, with the other age groups, it's only a minority that didn't live there. And then when you look at the 35 to 64 age group, a majority of them lived in the city before. I'm using this just as an illustration that people move. People move in and out of cities, and in particular, young people move. And this is a phenomenon that's true worldwide. And I am saying all this by way of trying to bring, I suppose, demographic observations about urban living with our thinking about the production of health. You have dynamic places that are growing and changing, where people are moving to these places, and in particular, young people are moving to these places. These are then cauldrons of real change that are going to be shaping the health of whole populations within cities and modally of the entire world over the next 10, 20, 30 years. And part of the change is a change in the physical infrastructure, an improvement, by and large, in the urban physical infrastructure. This is proportion of urban population living in slum areas by regions worldwide. The gray bar is 1990. The blue bar is 2010. This is from a WHO report. And what you see is the proportion of populations living in slums, and slums, by the way, is the technical UN term, but really is referring to informal urban settlements, has been decreasing in all regions. See, it's decreasing in all regions. And when you look at it this way, how many people how much of the population has been lifted out of slum conditions? We have places like Indonesia, Morocco, Argentina, where we have lifted over 10 years nearly half the population out of slum conditions. So there's rapid improvement in infrastructure in many cities. There is infrastructural investment. There's actually infrastructural investment here in Atlanta, as I've been hearing about. This is in Bogota, which is a city in the capital of Colombia, which for many decades was known largely for violence. Now it actually has a terrific rapid transit system. This is Sao Paulo, which is also another rapid transit system. And as all that happens, other changes come about in cities. Cities get more expensive. This goes back to what happens every time I bring up cost. This goes back to Washington, D.C., and these are rental prices. The blue, the sort of bright blue bar, is the most expensive rental price, and these are the least expensive. And what you see over time, things are getting more and more expensive. So cities change, the places change, and the policies that shape cities change. In a very interesting book that was just published recently, Bruce Katz published a book, Metropolitan Revolution, arguing that cities are, in the United States, he has a very US lens, are the most innovative engines of policy growth. And I think that's debatable, but it's an interesting argument. But just focusing on New York City, things which I've been involved in the past few years, New York City has seen this development of things like smoking ban in public places. And it also has seen failures of efforts to regulate sizing and marketing of sodas, for example. But these are innovations that have emerged in cities. And one can think of many other examples that way throughout the country and in many parts of the world. So cities are a place where policies can grow in many respects. The policies can grow and emerge, not beholden to some of the special interests that happen on the national scene. And cities have shown, particularly in the past decade, nimbleness and a capacity to create policies that, of course, many of which are directly linked to and can influence health. So now I want to come back to health. So I start off with cities. Obviously, I'm talking in an event sponsored by a School of Public Health. So at core, I am interested in health. I am, as Dean Erickson said, I'm a physician, I'm an epidemiologist. I'm interested in health. So what does all this have to do with health? Well, about 25 years ago, when the notion of urban and health began to be used together, much of our thinking around this was around this term, the urban health penalty. Cities were being considered as bad. If you think about cities and health, cities were being considered as a negative. And the term the urban health penalty, if you look at literature, public health literature, 20 years ago, this was used all the time. We actually published a paper trying to rebut that about 10 years ago, talk about towards an urban health advantage. And in fact, at a crude level, this is probably my favorite New York Post headline ever. It's from about 10 years ago, which says, "Long live New Yorkers, life expectancy here now tops the country's." And at a crude level, the health metrics in cities are better than they are in non-urban areas, which now that I've told you about the concentration of resources should come as no real surprise. When you do a simple search on PubMed for urban health, this is the number of papers you find in PubMed over the past decade plus, with a lot more interest in how cities affect health, which is to be expected given the greater concentration of people in cities and given the greater relevance of cities to the health of all our lives globally. In 2005, about 10 years ago now, we published a model that asks how is it that cities shape health? And I'm just showing you this here just to guide you through what I think are some of the core ways in which cities affect health. And I think this still holds today. There are major global national trends, things like migration, things like suburbanization. These trends influence municipal governments, government policies, food, housing, labor policies, civil societies. And those influence living conditions, demographics, physical environment, social environment, health and social services. And that influences health outcomes. In a perhaps self-aggrandizing move, we actually put public health intervention and research right in the middle of the production of health in cities. I have days where I'm not entirely sure about the wisdom of that, but our intention behind that was to say that public health, and by public health we mean public health academy, the public health academic institutions, as well as public health practice, have a clear role to play in shaping the health of urban residents. In a recent paper from a Lancet commission, this was a conceptual framework that they put forward about how health outcomes are influenced by cities, and they talk about built environment, society and governance, aspects of the built environment, and urban planning and management, which roughly, these things echo some of the things that I just showed you in the previous diagram, although this has better graphics. When you look across cities, look at life expectancy in the United States, blue bar is total, the green bar is men, the orange bar is women. You see in large metropolitan counties, people are living longer than in medium, than in small, than in rural. In the US, people living in cities are living longer. Some risk factors, prevalence of obesity is risk factors in the US. This is urban areas, less sedentary lifestyle, less cigarette smoking, less obesity. Positives on other dimension, things like social supports. This looks at urban versus rural, emotional support, belonging, tangible support. This is in particular was an Australian study looking at supports available to gay youth, showing much higher social supports in urban areas. So at a crude level, there are clearly positives on some of the health indicator outcomes that we might be interested in. There are obviously, at the crude level, negatives. This is a simple curve looking at the urban heat island effect, showing that within cities, with the more built-up cities right here, you're going to have greater surface temperature both day and night, which is associated with a whole host of health considerations. Anybody who spends time and travels in Southeast Asia knows that the rapid urbanization in Southeast Asia, the rapid growth of these cities, the rapid concentration of people in these cities comes with a price. One of those prices is pollution. Cities that actually look like this, although the truth is frequently you can't see them because of the density of pollution. And this is a clear dark side to rapid industrialization and the concentration of resources within cities. And inequality. And I just want to put one slide up on inequality and to make the point that I would be glad to spend an hour talking about inequality, because one of the core challenges that any talk that is charged with mapping out a framework for thinking about cities and health faces is that cities are not cities, that within cities there are many different cities, and that concentration of resources brings with it the urban haves and the urban have-nots. And cities have tremendous heterogeneity within them that we run the risk, as this demographic tidal wave and this change in urbanization worldwide, of creating groups in all over the world. This is looking at Africa, America, and Asia, looking at the under 5 mortality among the urban poorest 20% and the urban richest 20%, showing tremendous gaps in all continents of the world. And that if we are to think about health of urban populations, we have to think both from an overall efficiency of promoting population health, as well as the equity considerations of the overall considerations about promoting urban population health. Now, much of the work in the field, apart from understanding this bigger picture view, has moved to, correctly in my estimation, trying to understand what it is about cities, what is it within urban areas that one can think of as being linked to promoting or health or being antithetical to health in cities. How can we frame the health of urban populations as a product of intra-urban characteristics? And that, of course, is important because if we are to be the public health practice and research arm that is in the middle of that causal frame, we need to think about where we can intervene. And our capacity to intervene at the whole city level is going to be relatively limited. The question is, what is it about cities that we can act on so that we can manipulate levers effectively to improve the health of urban populations? One way to understand that is to look at intra-urban heterogeneity, to look at these differences within cities. And you see this worldwide. This is in Jinju City, South Korea, where what you actually have here is population, it's density of populations that are vaccinated, having almost an order of magnitude difference within the same city, showing areas with high vaccination, areas with low vaccination, very clearly linked in this particular study to the placement of accessible community health centers. Going to New York City, where I live now, there's a map of New York City. Those of you who don't recognize it, that's Manhattan right there. And this is a percent of people who are obese in New York City. The darker the color, the more obesity. And what you see here, the South Bronx and Central Brooklyn are areas of high obesity. In fact, in Manhattan, obesity is quite sparse. In fact, the previous health commissioner, who is currently the head of CDC, had once said that if only we can figure out what the special magic that Manhattan residents have, we can bottle it, we can deal with the obesity epidemic. He also referred to South Bronx as the ground zero of the obesity epidemic in New York City. So there's a very clear geography of these health conditions within cities. It's not a simple matter of saying cities are less obese than rural areas, which is true. It is perhaps as, if not more informative, to say what is it about the intra-urban geography that is promoting this versus that. There is a growing body of scholarship around this notion of urban characteristics and health. Those of you who are engaged in this work will recognize that much of this has passed using the word neighborhoods and health. I am not using the word neighborhoods on purpose because I think the word neighborhoods has become freighted with arguments about what exactly is a neighborhood, and I'm not sure that those are as productive, particularly given the multiple meanings of the concept of neighborhood. But studies on urban characteristics and health include, for example, studies like this one, which show this is an adjusted mean reading score for children as linked to aircraft noise, showing a decrease in reading scores in kids linked to aircraft noise. And of course, I could then show you this mapped onto urban resources, particularly family socioeconomic position, in that the families where there is most aircraft noise are the ones which have lowest income. This is from another study where we had looked at characteristics of the physical environment. It's not enough to say, well, the physical environment. Well, what about the physical environment is associated with health? And this looks at building external characteristics and building internal characteristics that were looked here in this context with depression. I think there is a growing body of work which is combining an urban lens on the production of health with a biological lens on the production of health, which I call here how cities get under the skin. I think some of this work is quite interesting because it looks at the macro-social view of urban characteristics and asks, okay, how is it that that macro-social perspective becomes imprinted in, manifests in my health, pathology in me, or well-being in me. This is from a study in Mexico City, which is a little bit terrifying for anybody with children, looking at an 8-year-old girl, and this follows her forward in time. And what they're actually looking at here is hyperintense white matter right there over the span of about 6 months, linked clearly to her pollution exposure, which of course then explains many of the other higher level observations around pollution exposure and reading and functioning. This is another paper that looked at urbanicity scores, as looking particularly at stressors in urban areas, and looking at brain function and as linked to urbanicity and urban stressors in case and control studies, showing very clearly that exposure to urban stressors is associated very much with clustering of hypodense areas in the brain. And this study makes an effort, this was done in Baltimore, to move us beyond the notion that ultimately our health is writ in our genes and inviolable as such. This looks at particular genotypes, and the ApoE3 genotype in particular, which has actually gotten a lot of press, and looks at difference in domain scores around multiple axes, language processing speed, and hand-eye coordination, executive functioning, showing that those particular genotypes are associated with higher functioning on these areas when one is not faced with stressors in urban environments. And last slide on this, perhaps my favorite, looks at physical activity and BMI. So we all know that physical activity, more physical activity, less body mass index. Here, what the study looked at was particular genotypes, looking at the AAGA and the GG genotype in the FTO gene, and showing that while overall there's a line like that, more physical activity, less BMI, if you have a particular genotype, which in this case is the AA genotype in the FTO gene, you are much more likely to have a steep gradient in the link between physical activity and BMI than if you have the G genotype when your line is essentially flat. And why I think this is a very interesting study and important for anybody interested in understanding how the urban environment influences health, how the urban environment gets under the skin, because it is showing that the production of health of populations is as much an aggregate of our individual biology, an aggregate of our social circumstances increasingly shaped by us living more and more in cities, as much as it is at the intersection of those two. And I think a scholarship of urban health going forward needs to grapple with that, needs to understand that it is a combination of the urban environment, the individual circumstances, and the biology that all comes together to produce health in populations, because ultimately health is a pathophysiological process. So I'm now going to move on to research and measurement for the last three numbers of my talk, and then I'll wind down. One of the, I said earlier that I'm not using the word neighborhood. I'm using the word neighborhood because I think it distracts us from a more fundamental question that says, if we are interested in cities and health, we need to be able to measure cities. We need to make sure that we measure cities well. And there are multiple different ways in which we can measure cities. And I want to show you perhaps a more old-fashioned way, a more shoe-leather way, and a bit more of a cutting-edge, technologically sexier way, and make an argument that I think there are multiple different ways in which one can measure cities, and different ways can lend themselves to different research questions. It's from a study we had done in Detroit, where we're interested in characterizing neighborhoods in Detroit, where we actually had teams of people going around Detroit residents. They were looking at characteristics of the built environment, like external building conditions, and they were creating maps that we could then use to map out external building conditions in Detroit, looking at things like graffiti and creating maps of where the graffiti was. And what we were doing was we were characterizing the physical environment in Detroit because we're interested in understanding how is it that aspects of that physical environment are associated with particular health indicators. You're interested in walkability. It's not a good way of doing it. One of the ways in which our extended team has done this is by giving people pedometers. This is a map of people walking. This is Lower Manhattan. And you see here, All these the red lines are people walking. And you see how red lines go in the water? Anybody know why those people walking in the water? No? They're not all Jesuses. No, it's the Staten Island ferry. Staten Island's over here, so there are actually people taking the Staten Island ferry. And we've used this to create things like this. This is actually a walkability map of New York City. And what you see, it's not surprisingly, Manhattan is densely walkable, much less walkable in Staten Island, much more patchy in these other areas. And we have studies, which I'm not showing you here, looking at a very clear correlation between walkability and BMI, with living in a walkable area and body mass index in parts of New York. Other ways, which I'm not showing you here, that have been used and are increasingly being used to measure cities are using more digital technology, satellite technology, things like Google Maps. I think that technology is coming. There's no question about it. It's still in its infancy. I have not seen that many papers yet that really capitalize on the potential of technology to capture cities. I think the bottom line that I want to make here, and make sure that you take from this, is that we should be using any and all technological means at our disposal to characterize cities. That if we're interested in an urban health agenda, we should be characterizing cities as well as we can, and we should make sure that we are trying to understand the characteristics of the urban environment and measure them as precisely as we possibly can. I made a reference earlier to the fact that cities are dynamic and cities are changing. And fortunately, there has been a growing understanding of the place that changing cities might have in improving health. There have been a couple of UN reports. This one's called Why Urban Health Matters. And in it, WHO has been calling for action on promoting urban planning for healthy behavior, which by and large is more at the rhetorical than at the pragmatic phase. Improving urban living conditions, building accessible and age-friendly cities, and making urban areas more resilient to emergencies and disasters. So this stuff is out there. It has been put out there that we need, as far as I'm concerned, the most important one here is here, which is promoting urban living for healthy behaviors, that we need to wrap our brain around what the urban environment does to our health, and therefore when we are building and contributing to the urban environment, making sure that we do so in such a way that it promotes the health of populations. That the urban environment is not manipulated simply for aesthetic purposes, simply for pragmatic purposes, simply for purposes of making sure that people and cars and other vehicles move around cities more efficiently, but it is also manipulated in such a way as to improve the health of populations. And in another WHO report, this is the Global Forum on Urbanization and Health in Kobe, there's very clear call that it needs to involve health practitioners, local governments, citizens, urban planner, all together to promote health in cities. And I think some of this call has been heeded. There are some very exciting examples of change in a positive way in urban areas. This is Milan, Italy, where a green belt was created explicitly to promote physical activity. This is Portland, Vancouver metropolitan region with dramatic public-part access. Places like New York City have been experimenting with inclusionary housing programs as a way of trying to make sure that there is affordable housing. And this is something you may have read about, which is the FRESH program, which is the Food Retail Expansion Support Health Program in lower income communities in New York City, as a way of dealing with the issue that got a lot of attention about 5 years ago, this notion of urban food deserts, to make sure that there is fresh food available in urban areas. I think some of the most exciting changes in cities are infrastructural and changing cities' accessibility and walkability. These are a couple of conceptual figures looking at changes in two particular towns. This is in Mount Pleasant, South Carolina. This is roughly what Mount Pleasant, South Carolina looks like at a particular intersection. And this is Urban Advantage, which is a group that really works on improving urban environments for the sake of improving those environments and with obvious implications for health, as we've been talking about in this talk. So this is existing conditions. It's adding sidewalk, adding trees on the far side, street trees on your medians, street trees on your side. You increase street life. You can then add light rails. And better yet, you can actually have a mixed residential development alternative. That's in South Carolina. Here's another example in Naples, Florida, which is, you all know that this is what many American cities look like. And showing very briefly that you can actually add street trees on both sides, parking cars, and shops, really changing the face of cities. And I think some of these efforts, some of which have come to fruition, are very exciting. They're very exciting ways of American urban areas to reclaim pieces of land that really have been quite desolate and definitely not salutogenic. There have been some interesting studies, very few though, that have shown how health improves with these changes. This is from a paper that actually just came out last week from the MESA study, looking at built environment characteristics and looking at difference in annual change in these various characteristics, and showing, for example, that by changing social destination, you are in adjusted and unadjusted models improving the likelihood that you're going to have better walking and lower BMI. So I want to conclude now with, okay, so having said all that, where do I think it's all going? So this is goes back to my urban health searches. If one does a simple urban health search, you get about 2,000 searches. But if you add the word longitudinal, only about 400 of those come up. One of the challenges in the field right now is that much of our observations around urban health and around the consequences of city living are cross-sectional and descriptive. And as a result, we do not have much confidence about what one should do to change cities, to improve the health of populations. How is it that we can leverage the dynamism of the changing conditions that are informing city changes worldwide to better get at health globally? Our majority of research is cross-sectional. It compares urban and rural areas. We're studying inequality in health and services within cities, not much across cities. And there's very little interdisciplinary work, actually. It is perhaps shocking, but there's relatively little interdisciplinary work. My shorthand for where we're at in research is go back to the conceptual diagram that I used earlier to say, how is it that cities affect health? And I suppose I put green box here, an amber box here, and a red box here. That much of the empiric research we have out there is over here, looking at how characteristics of physical environment, excuse me, some social environment work, some work on health and social services within cities affect health outcomes. There is growing work about how interventions go on to shape health outcomes. We really have next to no work about how municipal level actions, policies, markets, civil societies, broad global trends can be manipulated for the purposes of improving the health of populations. And when one stops and thinks about it, if we are working within the domain of public health, where our core function is to improve the health of populations, to assure the conditions so people can be healthy, this is, in many respects, where a lot of our research can be, because this is where we can affect change that can affect thousands, tens of thousands, and hundreds of thousands of people at a time. So in some respects, it is a call for a shift in our research focus from here to here, although fully accepting that all of it is part of the causal frame that produces health within cities. There are people who are noticing this more. This is a complexity of causation in urban context. These are some headings from an urban conference. And just to give you a sense that I think more people who think about these questions are beginning to realize that this is the challenges where we should be going. So I want to conclude on 2 slides. Make sure it's time for a couple of questions. And I conclude with my, my pet goldfish slide. The reason I'm putting the slide on is as a metaphor. And one of the challenges the goldfish faces is that if its water gets cloudy, it doesn't really realize it because the water gets cloudy slowly. And frankly, it's all the water it knows. It's got no source of comparison. And in many respects, urban living is like that for all of us. It is the modality within which we live. We have really no way, frequently, of stepping outside of ourselves and saying, how would our collective health be better if our environment were better in all its dimensions? And for most of us, that is now the urban environment. How would the health of our population be better in a counterfactual that says our city were greener, it had buildings that promoted social interaction, it was more walkable, there were more infrastructural projects that made sure that our health systems were functioning efficiently, and it had the institutions in place to promote equity. How then would our collective health be different? And it's a very difficult lens for us to adopt because we are, like the goldfish, in the urban water, and it's very difficult to step outside of ourselves and say, how could this be better if our water were better? My last slide I want to conclude with this classic New Yorker cartoon. For those of you who hadn't seen it, this is New York as seen from 9th Avenue. And the conceit of this New Yorker cartoon is that you know, this 9th Avenue, 10th Avenue, and then there's the Hudson River, there's New Jersey over there, and over there there's China, which really is a view of, it's very much a view of how New Yorkers see the world, which is there is New York, and, you know, there are a few other things, but more importantly, there's a deli on 10th Avenue that I really like. As Dean Erickson mentioned, I'm in the process of leaving New York. It's my second time leaving New York, actually. So I'm now finding myself in discussions with New Yorkers who are like, oh, yeah, are you going like past Jersey? Like, where are you going? Like, it's over there somewhere. And I'm showing this because I do think that the magic, the really interesting areas of scholarship in this are going to come at the interstices of both disciplines and of approaches, where we see cities as dynamic, interesting, changing places that are becoming the modality of not just where we live, but how we live, how we feel, how we think, how we behave, the water we drink, the food we eat. And the core question that we should be asking is, how can we then manipulate those environments for the sake of improving the health of populations? And I think a science that demonstrates how that change is associated with positive change in health indicators can lead us to a policy and practice that optimizes cities for the better health of all. I'll stop there. Thank you for having me. Would you like me to take questions? I'd be delighted to.
Hi, Dr. Galea. Thank you so much for that wonderful talk. You may know I have a growing interest in neighborhood change, and you brought up an article by John Hirsch and the Mesa Group looking at neighborhood change. There was also another paper in AJE that recently came out showing that using a fixed effects approach, showing that neighborhood change is not causal for some acute health outcomes. So my question is really with these macro level interventions that occur, like the health inclusion interventions in New York, so that we are able to really adequately assess the change and the impacts that they have on health. If you have any insight or recommendation.
I think it's a great question, and if I may take the question up one level for a second and then come back down, I think you're getting at the notion of the relatively unique and very fertile opportunity that many of these natural experiments in cities afford for inquiry. And I think that's a terrific point. In many respects, right, it's a two-way street. I think researchers, those of us whose job it is to produce the empiric evidence, need to be alert and aware of these opportunities, but we also need the policy and the planners to be open to collaborations that allow us to produce the data that we need to produce. So I suppose, as I see it, part of the purpose of pressing on this idea that cities affect health and that it is our collective responsibility to optimize cities for the production of better population health is so that we have growing awareness on both sides. I think you can't, some of these natural experiments you can do research around them, some of them you can't, you really need involvement. One of the challenges with the observational work, as you said, there's been conflicting evidence from the MESA studies around this, is that these are such complex processes that it's very difficult to come up with, certainly what epidemiologists like to think of as causal effects. So capitalizing on these natural experiments becomes really critical. I think municipalities are beginning to wake up to the potential of their actions. And what I'm hoping is that there will be a greater dawning of awareness that by documenting the consequence of these actions, it not only validates the actions of municipalities, if the data show that, but also allows municipalities to take an intellectual lead in influencing other areas. So I think it is for the benefit of all to integrate evaluation and research with these natural experiments. I think from a purely university-based research perspective, we need to do it. And I would argue that there are tremendous benefits to the large policy-making, planning organization, municipalities that are putting these in place.
how do we ensure that we don't fall into the same problem of having these gaps in the
Yeah.
address those when we
Yeah.
its effect on health?
Yeah, I think it's a great question. And I think it gets at the heart of this challenge between efficiency and equity, which economists have tackled, and in public health we have broadly danced around. And I think the challenge is as follows, in that if your goal is to improve the health of populations, it is not infrequently the easiest path to do so to improve the health of those who are already the haves and to make the haves even have more. And that but if you try to narrow intergroup inequality, it might take you longer to reach a more efficient outcome of better health for all. And I think that is a real tension in population health practice and population health science. And it's a tension that we have not addressed adequately. I think we have gotten away without addressing it based on a notion that, well, we can do both. But increasingly, I am beginning to feel that you really can't have it both ways. That we need to be clear about whether our core value that we are elevating is the narrowing the intergroup differences or the elevating the overall mean. And so I'm not giving you an answer. I'm trying to simply surface the challenge. I think you nailed it. I think it's a real challenge. And I think when you're talking about urban health intervention, urban health research, it becomes a real issue. And one can discuss then, what is it that helps guide you? What is the value set that guides you one way versus another? I think it's a really complex set of issues that arise. Thank you. Yes. Yeah. That's a really valuable question. Thank you. First of all, I always say this whenever I'm in a talk. I'm fortunate enough to have people from public health practice in the talk. I'm actually deeply grateful to you for bringing it up, and also always feeling very fortunate that in my perch I can just sort of say things without having to do anything. So I have deep respect for those of you who have to do something. I think it's a tough question. So I have, and I've tackled it in the past, and I have two answers to it. Neither of them entirely satisfactory, but these are the best two answers I can think of. Number one is that if efforts at producing change, where part of the goal is to improve the health of populations, are implemented in lockstep with an evaluation effort, you can frequently document some of the positive aspects of those changes sooner rather than later. Yes, the fullness of the change will take time, decades even, but if one were to build in efforts to evaluate potential short-term benefits, there frequently are such benefits. Now that requires the foresight to build in those efforts early. So I think, so number one is a call for that. The second approach, which I'm increasingly thinking has potential, is the use of modeling, is to be able to use early data to model change that's going to happen even if it's 10 or 20 years down the road. And in my discussion, certainly in my current municipal health context in New York City, health practitioners understand. They understand the limitations of modeling, yes, but they understand that if change is going to take 10, 20 years, we can at least anticipate that this is what the change is going to be 10, 20 years down the road. So the use of simulation modeling to say, given what we know today, given the change that we've seen from T0 to T1, with 1 being 1 year, here is potentially the change that you are going to see 10 years from now. And that is, in many respects, far more satisfactory for those who are on electoral cycles, who need to be able to say that they have a 4-year horizon. Because it's one thing to say, well, I have a 4-year horizon, therefore I can't do anything. But it's another thing to say, okay, I get it. This is going to take 10 years, but I can at least see what's going to happen 10 years from now. And I think that concretizes the abstraction of saying there will be benefits after you are gone. You know, one of my favorite aphorisms, which I don't remember the exact words, is this notion that it's the mark of a civilized society that we can plant seeds for trees under whose shade we don't sit. Right? And that is part of what we're doing here. But pragmatically, understanding that there are those in positions of authority who have calendars that they are responsive to. So I think it's A, providing data that in the short term can be useful, and B, using that data to provide simulated modeling exercises that can tell us what we might expect 10 to 20 years down the road. Those are my two answers. And as I said, I don't think either of them is fully satisfactory.
More questions, Ms. One? If not, please join me in thanking